respiratory therapist, and my main study is the invasive mechanical ventilation domain on the practical platform. I've met some of you virtually already. I think I saw Kim's name there, and I see Carlos's name from Winnipeg. And so I do have a PowerPoint, but I was hoping that if you guys had any questions, we can interrupt my PowerPoint. I can go and you guys can share some troubles you've had or something you want to talk about. Yes, Kim?
Hello, everybody. How are you? I can probably do my camera too. Oh, having a little snack. So we luckily only have enrolled one patient. Unfortunately, they didn't continue the study. They withdrew about halfway through. We were on the conventional side of the program. The patient was on PSV. It was pretty, there wasn't any difficulties. After they withdrew, the research personnel went in to do some of their documentation, and they were looking for the PIP, which we do not routinely record on our ventilator flow sheets for PSV. So I just basically said, just add the two together. That wasn't what they wanted to see. They actually want to see a recording of PIP. Can you explain why we couldn't just add the two, or do I need to have the staff record PIP and PSV?
So I think the theory behind that, like I know mathematically, like technically, it's supposed to be the same, but I think with the compliance of the circuit and some other things, sometimes the actual PIP at the vent is different from just the addition of the pressure support and the PEEP. So I know I spoke to the sponsor once I got that question from your team, and since it's only going to be a handful of patients, the sponsor would like the PIP recorded on your IMV patients in pressure support.
Okay, great.
I hope that's not too much extra workload, but yeah, I know where you're coming from, Kim. But yeah, sometimes there has been a difference. Like even when I'm trying to just maybe doing it in my head on a couple patients, and then the ventilator reads like just 1 or 2 centimeters water off. So yeah.
Okay, no problem. Thanks.
Thanks. Just gonna share my screen. Don't be horrified by all my folders on my screen. Can everyone see my screen okay?
Yes.
Okay, thanks, Kathy. We decided to have these bi-monthly RT sessions, twice, one in the morning and one in the evening, to hopefully capture RT and bedside clinicians that are in the IMV strategies domain. I added my email and phone number to this slide. For those of you that don't have it, your teams can always reach out to me. I'm a bit more responsive on my cell phone. I can take calls, texts, FaceTime, WhatsApp. You can also send me an email if it's something longer. My response time on email is a little bit slower. So just a little quick overview about how the domain has been doing. We have, sorry, let me move you guys over a bit on my screen. We have 203 patients randomized in total to the IMV domain. 21 patients are co-enrolled in IMV, and Cordy2 is a steroid trial on the practical platform. 43 sites have been activated across 7 countries, the bulk being in the US and Canada and the US. We have 6 in Australia and 4 in New Zealand, 1 in Spain, 1 in Saudi Arabia, and actually I think 2 in Italy now as of our most recent meeting, and a few most recent activations in the US, being University of Kentucky, Cincinnati, and Pittsburgh. We started back in September 2023 at our site, and with the addition of all the sites, it seems that probably around July to October to September of 2024 is when we started really seeing an influx in our randomizations. Kathy or Yaya, if you can look at the chat or if there's any questions, because my screen is minimized, but I was just going to go a bit over the workflow, and if you guys want to interrupt me with questions or comments, concerns, please feel free. So basically, once the coordinators at the sites deem that the patient has met practical platform and IMV domain eligibility, meaning they met all the inclusion criteria and no exclusion criteria. The most relevant for the bedside clinicians and RTs kind of to make note of is mechanical ventilation for less than 72 hours, a PF ratio of less than 300, and acute hypoxemic respiratory failure not from PE, heart failure, fluid overload, or asthma. Then the ICU physician, or also called the MRP, agrees to the study. The SDM signs consent on behalf of the patient. SDM is substitute decision maker. There might be different terminology in different countries. And then the patient is enrolled. And once the patient is enrolled is when the RT and bedside clinician job begins. So the patient is placed on some pre-randomization ventilator settings. The modes can be pressure control, volume control, PRVC if you use at your site, and pressure support. The tidal volume to be 6 mils per kilo ideal body weight, or, in and around that ballpark, especially when they're on pressure control or pressure support. The PEEP 10, this might be new for some of the sites that I taught very, very early on. We've amended so that, before it said lower if needed to maintain a plateau pressure less than or equal to 30, but it can also be higher if you're on very high O2, and dropping the PEEP will significantly cause the patient to decompensate, as long as your plateau pressure is less than or equal to 30. If you're on higher PEEP and your plateau's above 30, maybe they're not quite ready to get in the study in that moment. And if they still have time in their 72-hour window, they should probably be reassessed by the coordinator. The respiratory rate can be, we don't request any range for it, just as long as the pH is maintained above 715 and the SATs 90 to 95. I always tell my RT or bedside groups that, like if your SATs are 96, 97, and you drop the FiO2 and they're still about 96, like I wouldn't sit there for 20 minutes trying to get the SAT exactly in 90 to 95. It could be a little bit higher for the blood gas. And then the protocol says after 30 minutes to come back, but we all know that working in the ICU is very fluid. And so sometimes you can put the patients on these pre-randomization vent settings, but you can't quite get back to them in 30 minutes. So we give a buffer about 30 to 60 minutes, and you return to do the airway opening pressure. One thing about the airway opening pressure, if the patient's on pressure support or if they're triggering in a control mode, then don't bother with this measurement and just make a note for the coordinator that it's not evaluable.
Hey, Georgie, it's
Yeah.
Carlos from Winnipeg.
Hi, Carlos.
Hey, I just wanted to touch base on whether ASV was, I know we had some text back and forth about ASV, but it is like a pressure mode. If there's been any chatter about allowing, if that is going to be a mode that's accepted on the study.
The sponsor, I went back to them after you asked me, and because they felt that it would affect the patient in, I believe is the driving pressure arm. I have to look back to my messages. They weren't, they didn't want ASV used at this time.
Okay, I'll make sure that our RTs know that. Thank you.
Yeah. Kim, I think you have a question as well, or?
No, I just can't figure out how to turn it off.
Oh, okay. Okay, no problem. Carlos, I'll get back to you. I'll look back at that email chain, and I can't quite remember right now because I don't use we don't use ASV at our site. So I was trying to remember what the sponsor had said it would, which intervention it would interfere with. So I'll get back to you on that.
Okay, sounds good.
Yeah. Oh, sorry. Was there another question?
Yeah,
Yes.
hi, this is Chelsea from UCSF, and I wanted to ask a question about the pre-randomization ventilator settings. If a patient was on control mode, however, we can't get the plateau pressure to near 30 for those 30 minutes, would we try to exclude this patient, or that it is okay to not have the values be exactly at the 30-minute prior randomization settings?
Like, Chelsea, do you mean like it's above 30, the plateau, or
Yes, yes. So we can't get it to below or equal to 30.
like it's too unsafe to turn down any of the pressures or anything for the pH and
Right,
for the, yeah.
right, yes.
Yeah, I think I would revisit that patient maybe when they're a little bit more stable then, because the sponsor was pretty particular about the plateau.
Okay,
All done.
Yeah,
okay, thank you.
you're welcome. Yeah, I think they were willing to like lose a little bit on the SAT, but the plateau they really wanted to be below 30 and below. Okay, perfect. Thank you so much for all the questions. So the airway opening pressure, if you have a Hamilton or Draeger ventilator, it has a PV tool and it's quite easy to use. You can see on the bottom of my slide, the practicalplatform.org website. Under the resources tab, there are videos where we're still trying to upload as many ventilators as we can. I recently just submitted for the Avia ventilator that I received from Surrey, BC, where they still have Avia ventilators that they're using. So those will hopefully be uploaded in the next while. And then the other vents that don't have the PV tool, namely this Servo, the PB 840 and 980. Trying to think what else you'll have to do a slow inflation curve to get that. And I've on the right-hand side of the slide is an image from the 980. And so for those settings, it's optimal to have them in SIMV volume control. And the reason for switching to SIMV is then you can go back to previous setup in the Servo and in the Puritan Bennett's so that your patient isn't ventilated for long on the slow inflation curve settings. Ideally, the tidal volume is 6 mils per kilo or safest for a plateau less than 35. a rate at 5, PEEP of 5, flow of 5, rise time on 100% on a couple of the ventilators, and ensuring that there's a square waveform. I don't want to spend time going to the website now to show you some of the videos, so that's why I just put some of these pictures up. So as you can see from the top picture, when the line just goes straight up, that means there's no airway opening pressure, and you just scroll the cursor to that point and jot that number down for the coordinator. When you're doing airway opening pressure and recruitment to inflation ratio on RT Maven, like you leave when there's no airway opening pressure, you leave it blank. So I had been doing that at my site too, actually with the data. And then we realized like we should just be charting. Usually this is 5. I've gotten 3 a couple of times. I've gotten 6. I've gotten 8 at this point, at this juncture right here. So whatever the number is where you put the cursor is what you give to the coordinator to put in the database. And then if they do have airway opening pressure, it's this first inflection point right here that you record in and around, try in the middle to get the cursor in the middle. On the 980, it's really nice. They have a grid feature that you can hit before you even start the measurement. So that's really helpful. So along with the airway opening pressure, if the patient's eligible to have one done, we need a full set of ventilator settings at that 30 to 60-minute mark, including the plateau pressure, the PEEP total, if you're able to, if they're in a control mode, and then POC and P0.1. If they're in a control mode, the POC and P0.1 are still on the database for the pre-randomization settings. If they're not, don't have effort or drive, just put 0 for that. And when they're triggering, obviously you'll get a value. And effort and drive are always negative. A third step for the pre-randomization, we'll need the elastance. You don't have to do any math. The database will calculate it, but they do need certain measurements. And that's why you're doing a full panel of vent settings, including the respiratory mechanics. For static elastance, they need the plateau, the PEEP total or airway opening pressure, whichever is higher, it does a calculation on the database, and the tidal volume. For dynamic elastance, if they're breathing, it uses peak pressure, PEEP, POC, and tidal volume. And then lastly, for pre-randomization, there's an ABG only if the arterial line is present. You don't have to do an ART stab. If there's no ART line, then don't worry about the ABG values. The coordinator can still randomize. And so right now there's 3 interventions on the IMV domain: conventional lung protective ventilation, or LPV, driving pressure limited, which is DPL, and lung and diaphragm protective ventilation and sedation, called LDPVS. And it's only at select sites. So if you haven't heard about it, it's not at your site, don't press that tab on the decision support tool. The physiological targets are pH above 7.15 and SATs 90 to 95. And then the measurements are dependent on the intervention. And so there's intervention sheets that you get into your startup package. Those have a lot of writing on them, but they do have the QR code to scan for the videos and for the decision support tool. The decision support tool is what is recommended for and it is part of the study to use. And it's actually very easy because the tool, you put in all your vent settings and the tool tells you if you're on target, and if you're not, what to do. I wanted to highlight, because on a lot of vents, either the P0.1 is red or it's a very simple push of a button on the ventilators. There's videos on a different tab beside the airway opening pressure. There's POC and P0.1 videos. I wanted to highlight the POC and especially for those of you that have used the decision support tool, the nadir. So to get a POC measurement, you have to do an expiratory hold. And so basically, you do the expiratory hold, it gives you your total PEEP, and then the patient will take an effort, and then the POC is the PEEP plus that piece of the low inflection point there. The tricky part is that the nadir, or the low inflection point, can be either positive or negative. So if your patient's effort is low, then your waveform is not going to cross the 0 axis. And so it's going to be a positive number. So let's say your PEEP is 10 and your nadir, your nadir is 2. It hasn't crossed the 0 axis. So it's 10 minus 2. So your total POC is 8, but because POC is an effort and it's always negative, it's -8. However, if your effort does go below the 0 axis, let's say your PEEP is 10 again in this example, and then your patient breathes below the 0 axis to, let's say, -4, it's 10 minus -4. And so your POC is 14, and because it's an effort, it's -14. The great thing about the app or the decision support tool is once you give it nadir and the PEEP, it calculates the POC for you. And so I would jot that POC that the decision support tool calculates somewhere because the coordinator will need the POC measurement for data, not the nadir. That was a lot. Does anyone have any questions? And my last slide is around the intervention stopping criteria. So death. The study runs for 28 days. So day 28 of mechanical ventilation. The goals of care are modified to no escalation, or the patient no longer meets hypoxemic respiratory failure criteria for greater than 2 hours. So this criteria is patient triggering the vent continuously in an assisted mode, or in pressure support, obviously. FiO2 less than or equal to 40%, PEEP less than or equal to 8, and inspiratory pressure, which is peak minus PEEP, or pressure support less than or equal to 10, and inhaled nitric oxide or ECMO have been discontinued. If after, let's say, so they were out of this criteria for more than 2 hours, but like at the 6-hour mark, one of those they go up to 50%, or they go up on the PEEP, or they go up on the inspiratory pressure or pressure support, then you're back in the intervention and back to using the decision support tool and taking the measurements.
Sorry, I have a question for you. It's
Yeah,
Kim.
sure.
We starting the study, the patient's unconscious, they're very well sedated, they're on their pre-randomized settings, we get the airway opening pressure, everything's hunky-dory. We put them on some type of AC ventilation, and lo and behold, a miracle occurs, and we want to put them on PSV a couple hours later.
Yeah.
That's okay?
Yeah.
Okay.
Yeah, it's happened to us quite a few times. It happened to us last week. We enrolled a patient. The MRP said, oh yeah, no, I'm not extubating them till tomorrow. And then lo and behold, somehow halfway through the day, the plan changed. They weaned the sedation. The patient woke up. We put them on literally on SBT immediately, and they got extubated an hour later. So they were in the study a total of, I don't know, 3 hours. So we had pre-randomization data, and that was about it. So yeah.
Thank you.
Carlos, I think you're next.
Yeah, I just wanted to something that's come up a lot, and I know that we've talked about it, Georgie, and but maybe other people have this issue too, is like when someone is on the conventional arm and they're spontaneously breathing, targeting that 6 mLs per kilo gets really difficult. As you know, patients can breathe like, one breath could be really large, the next breath really small. You try your best to target at 6 mLs per kilo. But then you're trying to take the numbers and you're like, okay, well, should I take it at when the patient is breathing at 8 mLs per kilo, or should I put that number in the decision support tool, or should I wait a little bit? So how would you suggest to navigate around this? Should we kind of watch the patient and pick an average volume or mLs per kilo or peak pressure? It's just really hard to figure out what PSV level to put the patient on when you're targeting 6 mLs per kilo.
Yeah, you're absolutely correct, Carlos. Like that's the trickiest part, I think. And to be honest, I know there's there's study people on here, but I try to get under the intervention criteria so I don't have to look at the numbers anymore. So I try to get them, if possible, to like because at that point when their tidal volumes are so variable, you almost like you can almost put them on like a 5 and 5, and then they're not, I mean, other than the FiO2, like maybe that's when it gets tricky. I don't enjoy keeping people on CPAP of 5, but I've put people on CPAP of 5 and 50%. And at that point, really, you like they're in like you can't really control the tidal volumes. Like if they're still getting huge tidal volumes on CPAP of 5, then it's
Yeah, I guess like I'm just kind of like, are the sponsors are they aware of this? Like, do they understand that like you can't really target a volume when someone's spontaneously breathing? Like, and how are they going to weed that information out in the study?
Yeah, we have brought it up a couple of times. I think they're still trying to figure out, I know the study started in 2023, but I think we're just like sessions like these where we hear from multiple sites and not just me talking about these issues. You know, we haven't really nailed down what exactly is a deviation. So like, for example, in this situation you're talking about in pressure support, like they're on support, you can't get them to no intervention, like because their FiO2 is still at 50%, but you're on as low settings as you can get or as moderate settings as you can get, and the tidal volumes are still huge. It's a feasibility trial, so maybe it's not feasible to measure tidal volume when they're pressure
Right.
support. Yeah.
Okay.
I wouldn't stress, and I encourage your team not to stress about it. Just try your best. Yeah. I think there's a question from Adrian.
Hello. Adrian from UCSF.
Yeah.
We recently had a patient that was enrolled into the DPL arm and had pretty significant low compliance. And we're on minimal PEEP of 5, and we're already on 4 cc's per kilo. And our driving pressure was still significantly above our goal. The clinical team attending was very hesitant to go less than 4, and I know there's no guidance on the minimal tidal volume. So, and the lowest we ended up going was 3.5 cc's per kilo. Do you have any guidance on situations like that, or where teams are unwilling to reduce their tidal volume because 4 cc's is the lowest we've have all gone typically since the ARMA trial. So I'm just curious if anyone or if you have guidance or anything to add to that, really.
Yeah, I think what like because we're not tracking tidal volume in DPL, I think what the protocol answer would be is try like it doesn't matter what your tidal volume is as long as your driving pressure is 15 or maybe 16, as close as you can get to 15. However, there is the safety aspect and the comfort of the clinical team as well. So I feel in that instance, Adrian, like having, and I know this might have happened in the middle of the night or on the weekend, I would say that in that situation, maybe having the clinical team reach out to your site PI for the study, or even I guess you would have a site PI, and likely in the States, Serena Sayeda out of Johns Hopkins is the main site lead of Drive in the US. Maybe worth, if it's not resolved at the local site, like reaching out to her and seeing what her opinion is. Because study aside, like patient safety and clinical team comfort is number one, really. Did that answer
Thank
your
you.
question in a way? Like I gave you the like protocol answer, like it doesn't matter if you're on 2 cc's per kilo, but whatever the site, I would escalate. Like in these situations, I've escalated at my site to obviously I'm in the research role, so but like I've escalated to my sponsors are at my site, so I've escalated to them on an evening shift or a weekend to see what they would think, what they would say.
Okay. Appreciate that. Thank you.
No problem. I think there's another question.
Yeah, I think the question is
Is it
from
okay? Sorry.
Wendy. Is that right?
Hello, can I ask a couple of questions?
Sure.
Can you hear me? The first question is I enrolled 2 patients, one in the conventional arm, one is the intervention arm. So in the intervention arm, one day the patient already meets the criteria for the hypoxic respiratory failure, no longer in that failure. So we stopped the intervention, we stopped measuring, but next day we have to increase the PEEP only from 10 to 12, from 8 to 10 and 10 to 12. So is it have to go back to the measurement, only just one criteria?
Any one of the like 5 criteria.
Yeah, only
you-
one, and then still need to go back
Yeah,
to the intervention.
yeah.
Okay. So, and the second question is, if the patient is already out of sedation, we don't want to sedate the patient anymore, and then the plateau, which is a POC, and the dynamic transpulmonary pressure is really high, more than 23. We tried all the measures, which is written in the apps, but thing is still not working. We have to, and then the study manager suggests is only have to sedate the patient and paralyze the patient to go back to the driving pressure measuring. But my clinician disagree with it. So all the way probably for a couple of days, which is the measurement for the transpulmonary pressure is really high, more than like 30 to 35. And then the patient still recovered, and then we didn't sedate the patient. And then that is a protocol violation.
I might defer to Yaya for the protocol deviation aspect of it. But yeah, like I think this is kind of a similar thing that I mentioned to Adrian, like it's a feasibility trial. So we suggest sedation, even like a light dose to see if it brings down the effort. But if the clinical team is not in agreement, I think it's worthwhile reaching out to the site PI and having a discussion and seeing what is best for the patient in that situation. But yeah, is that a protocol deviation then? Because we're way off target?
So typically, we obviously, as Georgie mentioned, we haven't really nailed down protocol deviations in relation to the intervention. But in general, if the team is trying their best to adhere to the protocol, and the patient doesn't respond, or as long as you're doing your best to adhere to the protocol, then it wouldn't be considered a protocol deviation. So yeah.
Okay. All right then. So we yeah, I just our doctors trying their best for the patients, you know, is you resedate patient and then get to the all the complication from the paralyzing agents, all that is really not worth it, just for the trial. So that's why we keep on what they normally do. So we just have to keep going and then extubate the patient, and then it's okay. The patient transferred to the ward.
Yeah.
Feel free to also email me with the details as well, just to make sure that if it needs to be logged or captured as a protocol deviation. And then
yeah, we already we talked to our study manager, which is in Australia. So she said that she'll mention it to the team, and then I think she might already done. But the thing is, I just wondering to know what to do in this meeting. So so it is all right. We keep on our decision, our clinician decision to not maintain the target. Yeah.
Yeah, like I think you try your best, but I mean, even at our site here, the some of the other MRPs that aren't on the study, like they find that a very hard one to try to follow, because we all know the negative effects of going back on sedation and especially paralytic as well.
Okay, thanks.
No problem. Any other questions? I know we've gone way over time. I'm so sorry.
Off topic, do they have RTs in Australia?
I don't know if Wenli jumped off. I think they have in PFTs, but I believe it's I think it's the physiotherapists there that do some respiratory therapy. Yeah. Okay, well, if there's nothing else, like I want to suggest to you guys, like I put my email address, it's all, and my phone number, it's also on the Practical platform. If there's anything, like we're doing these like every couple of months. So if there's anything you want me to focus on and change up, I have some suggestions from the morning group for the next session. But please feel free to reach out to me. I want to make these useful for you guys and hopefully help give you some concrete answers, or if I can't, if I don't have the right answer for you, I can, myself or Yaya or anyone from the osmosis team can reach out to the sponsor and ask them questions. Kim?
Last question. Can I have this recording sent to me so I can share it with Matt?
I think it was the morning one was sent, right, Yaya? They're going to get sent?
Yeah, we will. Kathy will be sharing the recording for this session too. It'll be uploaded on our YouTube channel as well as the Practical website as well.
Okay, thank you.
Yes, I see that there is a request to have the transcription as well. no problem. We can have that available too.
Okay, I think if there's no more questions, we'll end this evening's session. And for everyone who has an extra long weekend this weekend, enjoy. And for those that are working, I hope you have a good weekend.
Thanks, Georgie. Thank you.
Thank you. Thank you.
Thanks,
Bye.
Jo.
No problem.